Our final presentation is regarding connecting and coordinating the care team. Our statewide network is well established and the infrastructure is in place, but the need to continue to improve quality and reduce costs remains, of course. So the next stage is having the ability to embed intelligent and actionable data to notifications, and coordinating care tools such as the Medical Information Direct Gateway or Mitigate. And these tools are increasingly being used to deliver interoperable solutions to all members of the care team, including community-based organizations who are also involved in transitions of care. Our final presenters today are Maureen John, Product Sales Manager at MiHIN, and Nick Wincent, PharmD, Clinical Pharmacist with Blue Cross Blue Shield of Michigan. Welcome.
Thank you, Shelley. Good afternoon, everyone. I'd like to kick off the Connecting and Coordinating the Care Team session by first and foremost thanking Nick Wincent for coming out here today and representing the BCN Pharmacy Care Managers. I've had the pleasure of working with Nick over the past few months on the Mitigate pilot, and it's been my extreme pleasure to work with you, Nick, and all of the work that you have been doing to help us expand and remediate all of the TOC viewer modules within Mitigate. And so, as Shelley alluded to, with the increase in statewide health information data exchange in the recent years, we often find ourselves asking, how can we make valuable healthcare data within our statewide network actionable for care coordination needs? And with this in mind, MiHIN has developed a care coordination tool, Mitigate, to address costs and technology barriers associated with utilizing our statewide services. So Mitigate, or the Medical Information Direct Gateway, is a collective presentation of data within MiHIN statewide infrastructure. Mitigate is currently in pilot with Blue Cross Blue Shield of Michigan with their pharmacy care team as well as their wellness care managers. And we have just recently added Ascension St. Mary's PHO to this pilot group. From a technical perspective, Mitigate is a user interface that presents data for declared active care relationships into functional modules. We have a number of care coordination modules within Mitigate directly tied to the MiHIN use cases, which includes health directory, active care relationship service, discharge medication reconciliation, and admission discharge transfer notifications. Now, I'd like to take a moment to focus in on the transition of care viewer module, which allows end users to view 90-day admission discharge transfer notifications and discharge medication reconciliation care summaries for your active patient population within real time. Now, with the collaborative feedback we've received from the Blue Cross Pharmacy Care team as well as the wellness care managers, we have made significant updates to this TOC viewer module that you're looking at right now to meet the user workflow needs. A few of the examples of the updates that we've made to this module include an export functionality to download a PDF or a raw HL7 or XML file of an ADT or CCD care summary. We've also included a patient class filter for filtering by a specific patient class to focus on whether inpatient, emergency, outpatient, or observation patients. MiHIN is now currently continuing to collect and implement end-user feedback to help improve TOC viewer functionality during this pilot phase. And now, at this time, I would like to introduce Nick Wincent to the podium to provide an overview of the Blue Cross Blue Shield medication reconciliation program and the work that he's done to build onto this Mitigate pilot program that we're working on right now.
Thank you, Maureen. And thank you, everyone, for sticking around. I'm here today to just tell you a little story about our experience with MiHIN and how it changed our program for the better. To do that, the history with our program, we started medication reconciliation back in 2013 on the HMO side, added the PPO in 2017 after some streamlining and some successes. The program in its last iteration, prior to introduction of MiHIN and afterwards, has consisted of 4 clinical pharmacists, including myself, and 1 analyst who handles the data management side of things for us. The pharmacists all contact members discharged home from hospitals to go over their medications and perform medication reconciliation, which for anyone that may not know is just highlighting the changes that occurred or the changes the hospital made to make sure they ideally don't end up back in the hospital and reduce our readmission rates. We generally do that within 7 days after the patient gets discharged home. It was on the longer end of where we would have liked it prior to the introduction of MiHIN for a couple of reasons I'll explain as we go. The program in the past, the big rate limiting step for us was obtaining discharge summaries, specifically discharge medications, which, like I said, that's the number one thing, or really the only thing we need in addition to our claims history to highlight changes in medications made by the hospital and to go over those with the patient. So we had 3 main ways that we were doing that prior to MiHIN. We had nurses embedded in hospitals who worked for Blue Cross and Blue Care Network, and we would contact them, and if they had time, they could send us information, the discharge medications, after the patient goes home. The next avenue was we actually went out almost like door-to-door vacuum salesmen going to hospitals and asking if they'll send us patient discharge information after a patient goes home. We'll just send you information, a name, John Smith, and you send us back that discharge list. Most hospitals, and as most of you probably know, anyone in healthcare doesn't have a whole lot of extra time or extra staff, so a lot of hospitals didn't really want to get on board with that. We had a few that agreed, saw some value in what we were going to do, and a little return on investment, a small investment, sending us that, so they agreed to do that. There was a little bit of lag involved with them. That step or that method for acquiring our discharges is what kind of took the longest. If the staff didn't have the time, it might be a week, even up to 2 weeks sometimes before we got a discharge report. And by that point, there's not a whole lot of impact we can make calling a member. The last avenue, and really I think of as the coolest, was a couple of hospitals gave us kind of the honor, and really is an honor, of having remote access to their system, where we could log in and pull the discharge information that we wanted for our members. This was really neat because it allowed us to see not only the discharge medication list, which was ultimately all we needed, but it showed us labs, vitals, any progress notes, SOAP notes left by any of the physicians, just anything that happened while the patient was in the hospital. And that gave us a better clinical picture to maybe make a better impact for them. Where that gets unrealistic is if most hospitals don't want to share that with you anyway, patient information and security is so important. But if we had every hospital in Michigan and we had access to, that's a different username, a different password ideally, and a different platform for a lot of the different systems, whether it be Cerner, PowerChart, Epic, that you'd have to learn, which creates a lot of inefficiencies. So those are kind of the 3 ways that we would do it. We called it kind of beg, borrow, and steal internally, trying to get anything we could to make any outreaches we could, and a lot of time went into doing that. Once we received it, our pharmacists, as I said, performed medication reconciliation. We call the member. If we identified anything urgent, we could make a direct outreach to the physician of record, primary care doctor's office, let them know what was going on, and then they could intervene as appropriate. For everyone else, and even those urgent cases, we would send a written report to the office, just informing them of the interaction we had with the member, ultimately trying to get some hits for our HEDIS and STARS medication reconciliation measure. MiHIN really changed the game for us, and in a good way. I have circled here on the slide the medications at time of discharge. This is essentially a table of contents with the TOC viewer that Maureen showed when you open up a care summary. So we have the medications, which is ultimately all we need, but we also had everything else involved there and more on some of the patients, depending on what information the hospital uploaded or what happened while the patient was in the hospital. So it includes things like vitals, the patient's labs, those progress notes, alternate contact information, just all sorts of useful things for us that almost replicates the best of the world of having direct access to the hospital, as those couple of hospitals did for us in the past, because we have all that information, but instead of having multiple platforms like Cerner, Epic, and needing to learn how to navigate all those, it's all in one place. So you log in once in the morning, and you can look up patients all day until your heart's content. Throughout the process, as Maureen mentioned, we've been able to work, and we say here on a weekly basis, but really we reach out to Maureen sometimes on a daily basis if we have a question, a concern, something, an idea pops into our head, how we can improve the TOC viewer for our end user purposes. And I haven't told Maureen in the past, but our entire team's continually impressed. She gets back with us more promptly than most of our internal colleagues, so that's always pleasant. And then the feedback, as I said, kind of from the end users drives the product moving forward as well. The development of it, and then certainly IT, you know, they build it and have the viewer for us, but it takes someone clinical a little bit to look at it as well as a good partnership. You know, you may look at it from an IT perspective and have some lab values that the hospital put in, and it has potassium there and says 5,000. Someone clinical looks at that and says, well, that's not right. So we can let them know something's going wrong, and they'll circle back to the hospital or wherever, whatever facility is that's putting that in and get that ironed out so that it's optimal for everybody on both ends. The big highlight really for this whole thing is before and after for us. And like I said, our story before and after MiHIN. Before, the big rate limiting step was our volume. We had a hard time getting discharges, and we were taking anything we could get. Like I said, beg, borrowing, and stealing. A lot of times, timely notification was an issue, timely access to the hospital discharge, and then accurate member contact information. We had a hard time getting a hold of people. So we spent a lot of time doing a lot of digging and not actually talking to people and making an impact. With MiHIN, it gives us a one-stop shop, to put it simply, where we have the discharges from almost all the hospitals in Michigan being uploaded in a timely fashion. And it allows us a lot more flexibility to hopefully make a bigger impact and, again, streamline our efficiency in a lot of different ways. Used to be we'd get enough discharges to have our program running, but we might have some patients that were admitted for a stubbed toe that maybe we're not going to make a big medication impact on. With MiHIN, it allows us to focus on high volume hospitals with high readmission rates, and then focus more on disease states that might be more impactful. We can look at things like CHF, COPD, and you know, the like for high medication impact that we otherwise might not have been able to focus on. So that kind of leads us into the future of where we want to go with this. One thing that's very centric for our program itself is, I mentioned earlier we sent letters to the primary care doctor's offices based on the interactions we had to let them know we spoke with the patient. Ideally, what we like to be able to do, or maybe be able to do in the future, is have a means of uploading our own letters or our own interactions through MiHIN or through MiHIN into an outpatient chart, again accomplishing getting us those HEDIS and STARS hits and numerator hits. We want to increase access to everyone across our department, essentially, anyone that makes member outreach. Right now, it's just our medication reconciliation team of the 4 pharmacists and the 1 analyst, but we've got medication therapy management pharmacists that do outreach. We have clinical pharmacy case managers that make outreach for social barriers, financial barriers, and other medication questions for other purposes. And them having access to something like this with a lot of patient information, again, just lets us be a little more patient-centric and tailor our treatment or our intervention to the patient's specific case. And then the last thing is working with the MiHIN team, as we've already done, and as Maureen mentioned, showing the TOC viewer, putting a PDF for us to be able to download a PDF into the viewer, adding things like death indicator flag. That's something that we put on this slideshow already out of date. They already put that in for us. Lets us know if the patient has passed away ahead of time. And then the contract ID search, again, is very insurance specific with us. If you ask to look up a member, we don't ask what the date of birth and name is, we ask what the contract ID is. That's going to be more specific for us. So if there's a way ultimately that we can search by that, it keeps one system for us through all of our systems. And then one thing I would like to mention too is about disease-centric and being focused on disease state for us to make our outreaches. That's really huge for us, and making a bigger impact on those high readmission acuity disease states. Something simple to cut time. On that TOC viewer on the front page, we asked them if they could add a diagnosis indicator. How it used to be before was we'd need to look up John Smith, and then we'd need to open the PDF for the care summary, and then we need to read the care summary and find the discharge diagnosis. And again, maybe we'd find stubbed toe, and now we say, well, we don't want to do that. We've got plenty of supply right now. we asked them to add that so we didn't have to do that process over and over again. And it only takes a few seconds for us to go in and do those things, but compounded over a day, over a week, over a year, across your whole staff, that's a huge inefficiency where you save hours. So just adding that, as they did, it was on that first slide that Maureen showed, they just added an indicator there that said why the patient was discharged. So we don't have to open anything up, we can just move on to the next person. So just little things like that that really streamline it for us. And again, the bottom line is it's a little anecdotal now because it's so early and we've been changing so quickly, but our efficiency and productivity has gone up so much through using this that, again, the rate limiting step used to be volume of discharges. Now it's just staff. We don't have enough people to do it. And we're already talking, it's a little ahead of myself there, but we may expand based on the new volume. We want to get a little data on impact with those disease states and targeting the higher acuity hospitals and things. But we'll take it from there. And right now, the sky's the limit right now because of this. I guess beyond that, I would just like to thank everybody for taking the time to listen to Maureen and I, and thank Maureen again for everything she's done for us. And are there any questions anyone has? Yes, sir.
Could you talk just a little bit more about the med reconciliation process that you guys undergo? What data you use, and then how do you communicate that back to the providers?
Absolutely. So thank you for the question. Our medication reconciliation process, medication reconciliation itself, again, for anyone that is unaware, is the process of comparing the patient's medications at home prior to an admission to a hospital to afterwards when they go home, any changes that were made. I'll use an example of a knee replacement as a pretty simple one. A patient, once they get a knee replaced, they're going to go on some kind of anticoagulation or blood thinner, which may just be something as simple as aspirin. But they started that, and it's very important for them to take that going home so they don't develop any DVT, blood clots, anything like that. So we obtained the discharge report from the hospital, which says, patient had a knee replacement, and we're starting them on aspirin or, something more significant. And then we will compare our claims history, which gives us a good indicator of the prescription claims or prescriptions that the patient's been on at home. Admittedly misses things like OTCs or anything that was paid cash. And then we have the discharge list from the hospital, which ideally will include things like that as well, and in our experience definitely does. It's a very comprehensive medication list. And then we'll make an outreach directly, telephonically to our member, to our patient, and speak with them about their hospitalization and then anything that's been going on since coming home. The nice thing, like I said, with having something like MiHIN or access to the hospitals is we have a bigger picture. When we have just the medication list, we go down it similar to a comprehensive medication review or a CMR with MTM, if anyone's familiar with that. Go over all the medications and any questions the patient has. Make sure that they picked up their aspirin or whatever new prescriptions were filled. From the insurance side of things, we get a unique aspect to be able to assist where if they were started on something maybe a little pricier, COPD is a good example with a lot of the inhalers and even some of the name brand blood thinners. If they require a prior authorization, some kind of coverage determination, we're in an ideal situation to get that taken care of for them, being at the insurance as well. So anything we talked about with them, making sure that they're taking the medication, again, if they have any questions, and then really if they have anything that we might be able to help with at all, like I said, we've worked with nurses internally and different departments, social work and things, we can make referrals as well for that. But we'll put all of that interaction into a letter, including a medication list, to the primary care physician, and we fax it to the office. Again, if there was anything urgent, the patient for whatever reason said, I'm not taking aspirin, I'm never going to take that. Again, maybe that's a low risk example for, most patients will take the aspirin, but we'll call the doctor's office and let them know, we spoke to the patient, they're very against this. And then again, most physicians' offices are very receptive to that and make outreach on their own, and they usually have a little better success having the direct relationship with the patient. So I know that was a little long-winded answer, but I hope that answered some of your question. All right, well, thank you guys very much.
Thank you very much. And I'm going to turn it over to Tim Pletcher to give us our close.
Thank you all. I would like to request your indulgence for the group that was just up here is part of the team that put together this whole event. And by whole event, I mean starting kind of all the way back to Thursday and Friday for our Connect-a-thon, Legal Day, and then the 2 days we've just experienced. And then we have the administrative team out front who's kept us very organized. So could we just have a big round of thank you and applause for them? We are going to do this again next year. So bring your ideas, give your feedback. Big, giant shout out and thank you to our vendors. You know, I've been coming for 11 years to these things, and I continue to be humbled by the amount of stuff that's been accomplished, these sort of armies of people who are trying to solve these problems. And just when I think I have it figured out, they introduce a whole bunch of new things to make me think that we're still only halfway there. And every year, I feel like we've made huge strides and huge progress. So I think Michigan, we should give ourselves a big round of applause because we've actually done a lot here. So we do have a long way to go, but I got to tell you, I come away more energized and more fired up about the potential than I did when I came at the beginning. So thank you all. We have a great community of people. We're mostly always working together to sort of put the patients first. And I think if we keep working together, we're going to get a whole lot more done. And Michigan as a whole is going to keep being out there in the lead. So thank you all. Get home safely. And we'll see you next year at least.